So one of my findings in screening her is that there is a little bit of tightness in the rotators of the right hip. Maybe you can see the foot. So I can rotate that hip in about 40, almost 45 degrees. When I spring it at the end range, there's a stiffness there. If we do the other side, you can see that she just rolls past 60 degrees easily and has a soft end feel. So that's one thing that we'll want to address. Her pelvis in standing is somewhat asymmetrical, but when she lies on her back, it's pretty significant. And I just don't know that the camera angle is going to capture this or not. But this hemipelvis is much lower than the other side. Now when I try and induce rotation through the right hemipelvis, the left raises immediately. And that's an indication that there's a restriction somewhere in the pelvis. When I induce motion on the left side, we don't have the same phenomenon over here. When we check the pubic bone, what we find is on the top, they are symmetrical, the height. But when I get on the face of the pubic bone, and the camera might be able to see that. I don't know if you can close up on that. But there is a distinct asymmetry from right to left on the upper third, on the middle third, and on the lower third. Most clinicians just check the upper third and the crest, but I find it very informative to palpate it in thirds. Now, she's aware that when I come here, I step down. When I slide off the right, there's a step down. Mm-hmm. So it is a shift, and when I come across here, I have to climb up a little bump. Mm-hmm. So she also feels that restriction. What we'll do is have you lie on your stomach, and we'll show you how that blocks the ischium. And so I'll show an anatomical model here. So what I feel is that this entire pubic bone is shifted posterior like that. And that's a pattern that I've described for about 30 years, certainly for 25 years. It's not in the body of literature. It's not in the traditional model. But you'll notice that when this shifts back, so does the ischium. So when she's on her stomach, what we would expect and what we find is that the left sit bone above the ischial tuberosity is prominent and it lacks posterior to anterior spring mobility. So let's have you lie on your stomach. And so we isolate the ischial tuberosities and then come up on that lower third of the pelvis, that flat portion, and she indeed is prominent on this left side. It's closer to the ceiling. Now I'll show you the normal side. On the right side, you'll notice I can immediately take up slack. So using less than 15 pounds of force, there's movement that's apparent. The movement is taken up, and then when I add an additional force, there's a spring mobility. There's a forward thrust and a recoil. Okay? On this side, I'm putting 15 pounds of force that's not moving at all. And now I'm increasing that, I'm doubling that, and I just can't get any movement through this structure. So that's that correlates with what we described. We've looked at the sacrum, and I don't find any asymmetry of the sacrum, and I didn't find any asymmetry of movement with the various spring tests. And the same thing with the pelvis. All of the mobility tests, inferior glide on both sides, superior glide on both sides, rotational movement, all of that demonstrated fairly normal mobility. But what I found is that a pelvis will oftentimes undergo permutation. So when you start treating it, it may reveal patterns that weren't apparent initially, and you just follow it. And it's a process of evaluate, treat, re-eval, treat what you find, re-eval, until in all directions mobility is normalized. One other thing with her pattern is that she has very free hip extension on the left. And on the right, it's considerably restricted. We noted this when she was on her back. Spring in the middle of the femur demonstrated block mobility. So that's if that's 5 degrees, that's all it is. So it'll be important to restore that hip extension as well. And she did mention that she was aware of herself walking abnormally. So this, I'm not going to, I didn't find a lot with the upper body screen, but as we balance this structure, we'll reevaluate the rest of the kinetic chain and see what spills out. So I'm very grateful for you allowing us to demonstrate this. We'll treat you and then we will refilm, and I'll give a summary of what the treatment was, and we'll see how the mobility tests change.